Welcome to the PMHNP Podcast, the definitive podcast for those passionate about mental health throughout every stage of life. Whether you're an aspiring professional, a seasoned expert, or someone simply keen to understand the intricate world of psychiatric care, you're in the right place. I'm Dr. John Rossi, a certified PMHNP, nurse educator, and lead content creator and instructor at Clarity Education Systems and www.pmhnptesting.com. All right, welcome back. Excited to be able to talk to you today about antipsychotics. One of the things that we're doing to also help with the understanding and learning of this particular topic is we have created an interactive learning environment for you to be able to read and click through and also identify some practice questions throughout the antipsychotic section. Again, this is just an extra bit of help that we're offering to those that are already in the program, and for those that are not, to at least give you something that you can utilize to help you prepare for your certification exam, and also to just practice if you're already a certified PMHNP and working within the clinical area. So there is a link in the directions or the description section of this podcast page. If you click on it, it'll take you to that learning experience, and hopefully it'll give you some more opportunities to study and learn. So before the introduction of antipsychotic medications, treatments for antipsychotic disorders were really limited and often pretty harsh. Common approaches included institutionalization, electroconvulsive therapy or ECT, insulin coma therapy, and psychosurgery, something like lobotomies. So these methods, they really aim to manage symptoms rather than provide a cure, and they often resulted in significant harm to the patient. Now, luckily, the modern era of antipsychotic medication began in the early 1950s with the accidental discovery of chlorpromazine or Thorazine. Initially, this was synthesized as an antihistamine, and chlorpromazine was found to have a calming effect on patients with psychotic disorders. It became the first drug used to treat schizophrenia and other psychotic conditions, revolutionizing that psychiatric care that we offered patients with psychosis. So that introduction year was 1950. The real significance of this was chlorpromazine's success that led to the concept of chemical lobotomies, so providing an alternative to invasive procedures. It helped to deinstitutionalize many patients and allowed for outpatient management of their symptoms. Now, following chlorpromazine, several other first-generation antipsychotics, and we're going to talk about what first-generation means here in a little bit, they were developed and characterized by their dopamine or D2 receptor antagonism. Now, keep in mind, they also did have an effect on all of the dopamine receptors, D1 through D5, but we really focused on that D2 receptor antagonism. These drugs, also known for and known as typical antipsychotics, they primarily targeted positive symptoms of psychosis, such as hallucinations and delusions. Now, the limitations of first-generation antipsychotics, especially their side effect profiles, led to the development of second-generation antipsychotics, or SGAs. And these were also known as atypical antipsychotics. Now, SGAs aimed to offer a broader spectrum of action, treating both the positive and negative symptoms of schizophrenia and reducing the risk of extrapyramidal symptoms, or EPS. Okay, so we saw clozapine or Clozaril. This was introduced in the 1970s, and clozapine was the first atypical antipsychotic. It demonstrated superior efficacy in treatment-resistant schizophrenia, but was associated with the risk of agranulocytosis, okay, so a potentially life-threatening decrease in white blood cells. This necessitated regular blood monitoring and limited its use to patients who did not respond to other treatments. So some of the other SGAs included risperidone or Risperdal, olanzapine, Zyprexa, quetiapine, Seroquel, Abilify, Guiadon, so lots of different drugs that come into play. At the end of this podcast instruction sheet, what I told you about earlier when we started, there's an actual chart of all of the first generation and second generation antipsychotics with their reasons or indications for use. So we'll talk a little bit about names throughout this podcast, but there's just too many to mention in discussion. So make sure that you check out that that chart, it's also available in the on-demand study seminars that we have for preparation. Okay, so as research on SGAs expanded, their use really extended beyond schizophrenia and included bipolar disorder, major depressive disorder, really as an adjunctive therapy at that moment, autism-related irritability and aggression, and many, many more. So we'll talk more about those here coming up. So this broadened that therapeutic application of antipsychotics and increased the number of patients who would benefit from these type of medications. In recent advancements in antipsychotic therapy, it focused on improving the safety and efficacy of these type of drugs, and we really wanted to minimize side effects and enhance patient compliance. So we ended up getting things like long-lasting injectable formulations to develop both treatment options for FGAs and SGAs. And this is going to provide that constant and consistent medication levels and improving adherence. So exploring partial agonists also helped out. So this helped to target other neurotransmitter system and reflect that ongoing effort to develop a more effective and safer treatment option. So there were some challenges and controversies that were initially introduced with the antipsychotic medications. First and foremost is going to be the side effect profile. So despite advances, antipsychotics still pose significant risks, and this is going to include metabolic syndrome, especially in the second generation realm, weight gain, diabetes, cardiovascular disease. So monitoring and managing these side effects is going to remain crucial. So checking that A1C, checking the patient's weight, going in and getting laboratory studies, especially for specific medications like Clozaril, when we have to watch for white blood cell levels. Okay, and then stigma and misuse was also another controversy or challenge that we faced. So the use of antipsychotics, especially in populations like the elderly or children, that is continually debated, with concerns about overprescription and the ethical implications of treating certain populations. Now, the future of antipsychotic therapy, it may include personalized medication approaches using genetic and biomarker data to tailor treatments to individual patients. Research into novel targets beyond dopamine and serotonin systems may also lead to the development of new classes of antipsychotic drugs with unique mechanisms of action and improved safety profiles, right? And we've even started to see that third generation antipsychotic realm come to play. And I think we'll see more and more as we progress in the scientific discovery. Okay, so now that we've explored the origins of antipsychotics, let's dive deeper into the class of medication and specifically talk about first generation versus second generation and how these medications not only help the patient, but we also have to watch out for those specific side effects profiles. So first-generation antipsychotics are also known as typical antipsychotics. They're primarily dopamine receptor antagonists. These medications work by blocking dopamine D2 receptors in the brain, which helps reduce symptoms of psychosis, such as hallucinations and delusions. Those are also positive symptoms, okay? I like to say that they're positive for the patient, so the patient alone is experiencing them. Nobody else around them is really going to know unless they say something about it. Hallucinations and delusions. However, their strong dopamine blockage can lead to higher incidences of extrapyramidal symptoms, or EPS, and other specific movement disorders. Second-generation antipsychotics, also known as atypicals, act as serotonin dopamine antagonists. So they don't only block dopamine receptors, but also antagonize serotonin 5-HT2 alpha receptors. That's really important to remember. This can help mitigate some of the side effects seen with typical antipsychotics, particularly EPS. So EPS is not the only thing that antipsychotics can cause, right? We have movement complications. We have things like, galactorrhea or prolactinemia or sexual dysfunction. So there's lots of different things that can occur. So second generations are associated with a broader spectrum of effects and are often used to treat a wider range of psychotic conditions, including bipolar disorder and major depressive disorder. So what are some of the indications that we see for antipsychotic use? First and foremost is going to be schizophrenia and schizoaffective disorders. First generation, primarily indicated for treating acute episodes of psychosis and maintenance therapy. They're particularly effective in managing positive symptoms, so that hallucination and delusions, and then reducing the risk of repeat episodes. For second-generation antipsychotics, they treat both positive and negative symptoms, things like withdrawal, anhedonia, ambivalence. So they're known to reduce relapse rates more effectively. So clozapine, that's an exception. It's reserved for treatment-resistant cases, and that's because of that side effect profile of, really having agranulocytosis and white blood cell complications. It's highly effective when other medications fail. Second indication is acute mania. So FGAs and SGAs, except clozapine, they can treat acute mania with psychotic features. So these are often used in combination with mood stabilizers like lithium, valproic acid, or carbamazepine. Other symptoms stabilize, so antipsychotics can be generally tapered off. Okay. Major depressive disorder with psychotic features, third indication. So the combination of first or second generation with antidepressant is effective in treating depression with psychotic features. Really, olanzapine and fluoxetine, it's a Symbiax, so it's FDA approval for treatment-resistant depression. That's a primary one that we look for during major depression with psychotic features. Fourth, delusional disorder. So first generations are indicated for delusional disorder and paranoia associated with personality disorders. Number 5 is severe agitation. So both FGAs and SGAs can be used for management of severe agitation, hostility, and hyperactivity, regardless of the underlying cause. So we'll sometimes see this as a treatment option, for a patient on the medical surgical ward or in the ICU when we need to treat that severe agitation and the ER. So they're also useful in children with severe autism to control behavioral disturbances. So risperidone, olanzapine are specifically helpful in managing aggression in children. Number 6, sixth medication, is Tourette disorder. So haloperidol, for example, is one of them, commonly used for FGAs for Tourette syndrome, while second generations may be used off-label for this particular disorder. So haloperidol and let's see, there's a second one here I want to mention, pimozide, are also the medications of choice for Tourette's. Number 7 is borderline personality disorder. So both FGAs and SGAs, they can treat psychosis and paranoia symptoms in BPD as well. Number 8, dementia and delirium. So a low dose of high potency first generations like haloperidol can manage agitation in dementia and delirium. Though caution is going to be advised here, okay, due to its risk of adverse effects in the elderly population and with elderly patients. So second generations are also used, especially for behavioral disturbances with the dementia and delirium. The 9th indication is substance-induced psychotic disorder. So antipsychotics can control severe psychosis secondary to that substance use. However, again, caution is needed for first generations during alcohol withdrawal and that intoxication period. Number 10 is childhood schizophrenia. So recent studies support the use of clozapine in treating early onset schizophrenia. This is offering benefits where other antipsychotics may fail. And finally, some other instances where we may use antipsychotics could be in treatments for Huntington's disease, Parkinson's disease, and also pervasive developmental disorders, though they are not the first-line treatment options. Okay, so we've talked about clozapine quite a bit throughout this podcast. Let's dive a little bit deeper. So clozapine, that's going to be reserved for patients who have not responded to multiple trials of other antipsychotics. It's also effective in treating tardive dyskinesia and is indicated for treatment-resistant mania, severe psychotic features, obsessive-compulsive disorder, pervasive developmental disorder, childhood autism, Parkinson's disease, Huntington's disease, and for suicidal patients with schizophrenia or schizoaffective disorder. So you can see that it really does have a broad range of use and for indications. Now, first-generation antipsychotics, we have a specific mechanism of action that we want to talk about. FGAs primarily inhibit that dopaminergic neurotransmission. They exert their therapeutic effects by blocking dopamine receptors in the brain. For optimal efficacy, approximately 72% of these receptors need to be blocked. Now, this action is effective in alleviating those positive symptoms in psychosis, again, such as hallucination and delusions. However, this strong dopamine antagonism can lead to a range of side effects, including EPS, which will result from dopamine blockage in the nigrostriatal pathway. Now, in addition to their effects on dopamine receptors, first generations also have varying degrees of antagonistic action on the noradrenergic receptors, and this can lead to orthostatic hypotension and sedation. Cholinergic receptors, and this can cause an anticholinergic effect such as dry mouth, constipation, urinary retention, and blurred vision. And then we've got this histaminergic receptor blockage as well, so often contributes to sedation and weight gain. Now, for second-generation antipsychotics, the mechanism of action is significantly different, and you need to know this main difference. So SGAs have a broader mechanism compared to FGAs. They block primarily D2 dopamine receptors, similar to FGAs, but to a lesser extent, which helps reduce that risk of EPS. Now, in addition, second generations also act as serotonin receptor antagonists, particularly targeting the 5-HT2 alpha subtype. The antagonism of serotonin receptors is believed to enhance the release of dopamine in certain areas of the brain, in certain regions, and this is going to help mitigate some of the negative and cognitive symptoms of schizophrenia. So this dual mechanism allows second generations to both treat positive and negative symptoms more effectively and to lower that risk of EPS. The 5-HT2 alpha receptor antagonism also contributes to that lower incidence of prolactin elevation and potentially less impact on weight gain and metabolic side effects as compared to D2 receptor blockage alone. So in summary, to just kind of, take a look again of these two different classes, FGAs primarily block D2s, leading to strong antipsychotic effects on positive symptoms, but with a higher risk of motor side effects due to that extensive dopamine blockage. Second generations block D2 and 5-HT2 alpha receptors. It's going to offer a broader therapeutic profile, including the treatment of negative symptoms and lower the risk of EPS. Now, there are some specific adverse effects on first-generation antipsychotics. We've already talked about EPS. Strongly associated with EPS, going to include symptoms like dystonia or sustained muscle contractions, akathisia or restlessness, Parkinsonism, this is going to be tremors, rigidity, bradykinesia, and tardive dyskinesia. This is that involuntary movements, often of the face and the jaw. Second adverse reaction we're going to look at for FGAs is an anticholinergic adverse effect. So commonly with low-potency FGAs, we're going to see dry mouth, constipation, urinary retention. Third is sedation. This is caused by the H1 histamine receptor blockage. We often see this with drugs like chlorpromazine being most sedating, and then fluphenazine, haloperidol, these are going to be less sedating. Fourth is severe risk of seizures. So FGAs can lower the seizure threshold, being more at risk for seizures as compared to a second-generation antipsychotic. So fifth is cardiac effects. Haloperidol can cause abnormal heart rhythms, including ventricular arrhythmias, torsades de pointes, and sudden death, especially when administered intravenously. Other first generations, like Thorazine, these are associated with QTc interval prolongation and have a black box warning for sudden cardiac death. Low potency FGAs, such as chlorpromazine, can cause orthostatic hypotension due to that alpha adrenergic blockage, typically occurring at the initiation of treatment, but often developing tolerance. Sixth is going to be endocrine effects. So FGAs can increase serum prolactin levels due to dopamine blockage in the tuberoinfundibular tract. And this is going to lead to galactorrhea or breast milk production. This is both in males and females. Breast enlargement in both males and females. Amenorrhea, this is the absence of menstruation in females. Impotence in men, and orgasmia in women. Seventh is dermatological effects. So chlorpromazine is associated with allergic dermatitis, photosensitivity, blue-gray skin discoloration, and benign pigmentation of the lenses and cornea. And thyroidazine can cause retinal pigmentation, which may persist even after discontinuation of the medication. Eighth side effect or adverse reaction is hematological effects. So rare side effects include leukopenia, thrombocytopenia, and other blood complications. And finally, number 9, this is neuroleptic malignant syndrome, or NMS. You definitely need to know this for your certification exam. So NMS is a rare life-threatening condition that can occur at any time during treatment. The symptoms for this are going to include hyperthermia, severe muscle rigidity, altered mental status, so things like confusion and agitation, autonomic instability, so fluctuating blood pressure, tachycardia. We're going to see an elevation in white blood cell count, creatinine, phosphokinase, CPK, and liver enzymes. And then finally, myoglobinuria. So this is muscle protein in the urine, leading to acute renal failure. So management, this is an immediate discontinuation of the antipsychotic for neuroleptic malignant syndrome. We do need to have immediate management in order to help the patient with NMS, and that's going to include immediate discontinuation of the antipsychotic, offering supportive care and administration of certain medications, such as dantrolene and bromocriptine. So adequate hydration, cooling measures, close monitoring of vital signs, and serum electrolytes are essential. Although NMS is more commonly associated with FGAs, like we talked about, remember that it can also occur with second generations as well. So one mnemonic that'll help you remember the symptoms of NMS is going to be fever. Fever. So fever, encephalopathy, confusion or agitation, vital sign instability, electrolyte enzymes, CPK and liver, and muscle rigidity. Okay, so when you go into the extra learning environment that I've talked about at the beginning of this podcast, you'll have a quick review of those adverse reactions. But I do want to kind of hit on some of the most commonly associated side effects, again, for FGAs. That's going to be EPS, extrapyramidal symptoms. Drugs like haloperidol, fluphenazine are going to be more likely to cause EPS, dystonia, akathisia, Parkinsonism, tardive dyskinesia. Second is that anticholinergic effect, low-potency FGAs, chlorpromazine, theoridazine, more commonly likely to cause anticholinergic side effects. That's that dry mouth, constipation, urinary retention, blurred vision, and cognitive impairment. Remember, sedation. We're looking at chlorpromazine as one that can really cause that. Most sedating among the FGAs because of potent H1 histamine receptor blockage. Others are going to be theoridazine, and a lot of them will cause the sedation, but let's remember those two specifically, and specifically chlorpromazine. Seizure risk, chlorpromazine, theoridazine. Cardiac effects, right? The theoridazine for black box warning of QTc prolongation and sudden cardiac death. Haloperidol for abnormal heart rhythms, to include torsades de Pointes, especially when it's administered intravenously. And chlorpromazine for that orthostatic hypotension. Endocrine effects, so risperidone, paliperidone, second generations. Though not specifically with FGAs, those SGAs are known for causing significant increases in serum prolactin levels. Dermatological effects, chlorpromazine, going to be allergic dermatitis, photosensitivity, blue-gray skin discoloration, pigmentation of the lens and cornea. Theoridazine can cause that retinal pigmentation. Hematological effects, that's going to be chlorpromazine, other FGAs, leukopenia, thrombocytopenia, neuroleptic malignant syndrome, all first generations. Haloperidol, fluphenazine specifically, it's going to increase that risk of neuroleptic malignant syndrome. Okay, so quick review. We just talked about all of them, but I want to make sure that those stick so that you can recognize the first generation side effects. All right, now let's talk about the adverse effects of a second generation antipsychotic, or SGA. So number one is going to be metabolic side effects. So SGAs are often associated with significant metabolic side effects, including weight gain, dyslipidemia, and an increased risk for diabetes mellitus. The FDA recommends comprehensive monitoring of metabolic parameters for all patients on SGAs, including personal and family history of diabetes, dyslipidemia, weight, height, and waist circumference measurements, blood pressure monitoring, fasting plasma glucose, and fasting lipid profiles. Specific medications that we want to take a look at: olanzapine, frequently associated with significant weight gain, increased appetite, and somnolence. Clozapine, also associated with weight gain and metabolic disturbances, along with a unique risk profile that we're going to talk about again here in just a few minutes. We've already kind of touched on it. Second is going to be extrapyramidal side effects, or EPS, and while second generations generally have a reduced risk of EPS compared to FGAs, some FGAs still carry risk, particularly in higher doses. So we can see this in medications like risperidone. This can cause dizziness, anxiety, sedation, and EPS, and paliperidone, known for EPS and temperature sensitivity. Third, for second generations, is cardiac effects. Some SGAs are associated with QTC prolongation, which can lead to cardiac arrhythmias. Some of the specifics include ziprasidone, associated with QTC prolongation, but almost no weight gain. Fourth is going to be sedation and somnolence. So SGAs can cause significant sedation, leading to changes in daily functioning. Specifics could include quetiapine, least likely to cause EPS, but is associated with somnolence, orthostatic hypotension, and dizziness. Olanzapine can often lead to somnolence. Number five is prolactin elevation. So elevated prolactin levels, this can lead to side effects such as galactorrhea, gynecomastia, and menstrual disturbances. So some specific medications for prolactin elevation. Risperidone is really known to elevate prolactin levels significantly. 6 is a unique side effects for clozapine. So clozapine is that unique drug among SGAs due to its side effect profile, and it's used to that last resort treatment due to its efficacy in treatment-resistant cases. Now, it's primarily associated with hypersalivation, tachycardia, and hypotension. Anticholinergic effects, and this is going to include dry mouth, constipation, and urinary retention. Now, the big one here is agranulocytosis. This is a serious condition requiring regular monitoring of white blood cells and absolute neutrophil count. So FDA guidelines: weekly ANC monitoring for the first 6 months, then every 2 weeks if normal. Discontinue treatment if the ANC drops below 1,000 cells mm cubed, or 500 cells mm cubed in those with benign ethnic neutropenia. Cardiomyopathy and myocarditis, rare but serious cardiovascular side effects also associated. Okay, the seventh one we want to look at are agitation and akathisia. So some second generations can cause agitation or akathisia-like restlessness. So specifically, we're going to be looking at aripiprazole, commonly causes agitation, headache, and those akathisia-like restlessness. There is an FDA black box warning. Both first generation and second generation antipsychotics carry an increased risk of mortality in elderly patients with dementia-related psychosis. Larger doses of antipsychotics elevate the risk of adverse effects, and that's going to underscore the importance of cautious dosing and regular monitoring. So we got to remember that black box warning. So what are some of the contraindications for first generations? So FGAs are going to be contraindicated in the following conditions due to that potential for severe adverse effects. So first is going to be a history of severe allergy, right? So patients known to have that allergic reaction to a specific antipsychotic need to avoid that drug and then any drug with similar components. 2 is use of central nervous system or CNS depressants. So barbiturates, benzodiazepines, opioids. These drugs can potentiate CNS depressant effects of FGAs. And that's going to lead to this increased risk of sedation, respiratory depression, and potentially fatal outcomes. Third is use with an anticholinergic medication. So combining FGAs with an anticholinergic can exacerbate anticholinergic side effects, and that's going to lead to severe constipation, urinary retention, and even delirium. Fourth, severe cardiac abnormalities. So patients with a history of severe cardiac conditions such as arrhythmias, heart failure, all should avoid FGAs due to that risk of QTC prolongation, arrhythmias, and sudden cardiac death. Fifth, contraindication is going to be seizure disorders. So FGAs can lower that seizure threshold, especially drugs like chlorpromazine and Thorazine, so making them risky for patients with epilepsy or a history of seizures. The sixth contraindication is going to be narrow angle glaucoma or prostatic hypertrophy. So the anticholinergic effects of FGAs can exacerbate these conditions, potentially leading to acute angle closure glaucoma and urinary retention. Number 7 is history of ongoing tardive dyskinesia. So patients with a history of TD should avoid FGAs, as these drugs can worsen or induce this condition, which can become irreversible. So for second-generation antipsychotics and contraindications, first is going to be increased stroke risk in elderly patients with dementia. So the FDA has issued that black box warning that we just talked about, indicating an increased risk of stroke and mortality in elderly patients with dementia-related psychosis when receiving an SGA. So these medications should be used with caution or avoided altogether within this population. Second contraindication for SGAs is avoidance with other QTC prolonging drugs. So SGAs should be avoided in combination with other medications known to prolong QTC intervals, as this can obviously increase that risk of life-threatening cardiac arrhythmias. Third is pregnancy and breastfeeding. So in pregnancy, antipsychotics should generally be avoided, especially during the first trimester, unless those benefits outweigh the risks. The potential for congenital abnormalities must be considered. In breastfeeding, since antipsychotics are secreted in breast milk, it's advisable to avoid breastfeeding while on these medications in order to prevent any of that exposure to the infant. All right, so to kind of end this discussion of antipsychotic treatment, I just want to talk about some additional monitoring considerations for these drugs. So we want to look at routine monitoring parameters, obviously metabolic parameters. Given the risk of metabolic syndrome with second generations, we need to monitor body weight, BMI, waist circumference, blood glucose, and lipid profiles, and this is regularly. Cardiac monitoring, regularly monitor ECGs, recommended for medications associated with that QTC prolongation. Hematological monitoring, especially crucial for clozapine, which requires that regular testing of absolute neutrophil count, or ANC, due to that risk of agranulocytosis. So ANC as well as white blood cell count. Prolactin levels, we have to monitor in patients taking second generations known to elevate prolactin levels. This is to manage symptoms of galacturia or gynecomastia. Okay, and then frequently we want to monitor the initial phase. More frequent monitoring may be required during that initiation phase or when doses are adjusted, and then in the maintenance phase as well. So once stable, the frequency of monitoring may be reduced, but should be still considered and conducted regularly, especially for high-risk populations. All right, so we've gone over a lot of information related to first-generation and second-generation antipsychotics. Remember, the primary difference between these two drugs is the mechanism of action. First generation is really going to focus on that dopamine receptor blockage. Really, we're looking at D2, but it will block D1 through D5, and we get a lot of side effect profiles because when we block one, we block them all. So all of the dopamine pathways, to include the mesolimbic, mesocortical, nigrostriatal, and the tuberoinfundibular pathways, all are affected by this dopamine antagonism of first generations. Second generation, again, we block primarily D2 dopamine receptors and 5-HT2 alpha serotonin receptors. And that is the big difference with these medications. Lots more information is covered in the on-demand seminars and in the in-person conferences. Love to talk about antipsychotics. They're wonderful drugs that have helped a lot of people, especially within the most recent years, as we have continued to have advances in medication management and medication profiles within the antipsychotic class. Please let me know if you have any questions. I look forward to talking with you and seeing you in future courses and in the on-demand PMHNP student portal, where we help you prepare for certification for the PMHNP exams. That's both the ANCC and AANP certifications. Thank you for listening today. Again, I'm Dr. John Rossi with Clarity Education and www.pmhnptesting.com.